name's Sarah Adams, and I work for Graphnet Health as Director of Health Analytics. But actually, I'm a lifelong analyst, I suppose, in the NHS is the way to term it. And what I'm going to do today, hopefully in this session, well, what I always do when I do presentations and when I'm working, with our NHS or health and care partners is I always try and explain what we're doing first in case there is anyone who comes and was expecting something different. So it's not a technical session today. It's a focus more on the softer side of the analyst role, and in particular, if we focus on what we do in Graphnet Health, which is population health analytics. And my aim today is really to share some of those, I suppose, like lessons learned that I've learned over the years, well, me and my team as well, about the things that go well, and then I suppose offer some type of framework in which you can work, which gives you the best chance of success, because actually nothing is perfect. And as analysts, we're always striving and thinking about how things can be different. I think it's our mindset and how we can change and improve things. So that's what today is about. And I hope as well, I want this to be quite a relaxed session. So if people do have questions as we're going along, do feel free to ask them, or just listen whilst you're eating your sandwiches, whichever works for you. So I'm just going to share my screen. Bear with me. And I don't want to do death by PowerPoint, but it is a PowerPoint presentation today, I'm afraid. Right, so let me just open this up. So we've got a couple of bits just to the agenda here. So I'm going to just tell you a little bit about Graphnet and just a tiny bit about my career as an analyst. And then I'm going to go into this sort of lessons learned and the framework to help achieve success, really. And I'm going to cover across these sort of 4 things that I've mentioned here on the slide. And when I talk about a framework as well for scoping, we have quite a structured way that we work in terms of population analytics use cases. And I'm going to talk through that and then share that with you afterwards if anybody would like it, because it might be a helpful document to have as well. So this little GIF here kind of made me laugh, because as analysts, we're all working on something that we think is absolutely amazing. And then have you ever had someone who said, oh, can I just export it out into Excel? Because it does happen quite frequently, doesn't it? So let me just move on. Right. So this is me, and the reason why I'm talking to you today is because Graphnet are sponsors of the Population Health Network within AphA. And myself and my teams, we've got many ex-NHS colleagues who work within Graphnet as well. But my whole career has been working with the NHS, and I love it. And I do it because I love it, because I don't think you work with the NHS unless you have a passion for it, because there's so much change and lots of different challenges that come with it. But my role has taken me from working in hospitals after I left university, and working initially as a research assistant, an information analyst, a performance manager, and very much doing that thing like, what are our waiting list numbers here? How are we performing against our commissioning targets? Right through to the spectrum of being a developer and also working with population health. And I always put in there when I talk about my career as being a mum as well, because that's a really important part of who I am too. And it shapes also how you look at things as an analyst as well. But my focus now working at Graphnet Health is very much on population health analytics, and I will talk a little bit more about what Graphnet do, just so you can understand the context in which we're working and shaping things. But what I thought was quite interesting was, I'm going to plot all of the different types of change that I've been through in terms of organisations since I've worked in the NHS, and there they are at the top. And then all the different types of programs and products that I've used over that time, starting right from SPSS, all the statistics. But when I worked for the NHS, access databases were king, and the VLOOKUP was the tool, because we used Excel spreadsheets. But I fast forward to my time as a developer using SQL Server as that tool right through to today, and it's all Azure, it's cloud-based, it's Python, it's Fabric and Power BI. And actually right there at the bottom, there's quite a bit of Copilot, isn't there, an AI that's coming in today, which has got the power. You could say it could be a threat, but it could also be a great power to us, and just in terms of things like efficiency, professional development in some ways as well, and trying to help us with what we need to do, because there's a lot of tasks that take a long time, and there's a place for it as well, which we know we've got to kind of figure out, especially how we harness that to its full potential within Graphnet for sure. I've just put on there as well Johns Hopkins ACG, because that's you know, quite a large part of what we've been working on over the past few years. So if anyone who doesn't know about that, that's about risk stratification and population segmentation that we have linked into our platform as well. So I've just stuck that on there too. So Graphnet, if I can get my slides to work. Graphnet, just so you know what we do for anyone who doesn't. So I suppose we provide a solution. I call it here like a digital ecosystem for population health. But I suppose our aim is to provide our health and care partners, so it's integrated care systems, with I suppose like a solution of different types of products for the most appropriate things. So, you know, population health, it's about, you know, being preventative, being data driven in terms of your case finding of patients, being more proactive, and, you know, that left shift that we're all talking about. It's about moving towards that perspective, you know, remote monitoring tools, evaluation and analytics to look at outcomes, planning and tools. You know, can you do assessments on patients at every single different, you know, care pathway? You can see, you know, community teams, general practice, can somebody at point of care see it when they go into it, when a patient comes into A&E? And it's really all about that learning health system, and I'll touch on that a little bit later, but it's about having a solution that's joined up, leveraging linked patient data, so that we can you know, improve the health of our population by really providing very actionable insights. But in terms of where we do it and what we do, so, you know, 11 integrated care systems, there's 20 million, you know, citizens' health and care records flowing into our shared care records, and in our population health solutions, 17 million records that get analysed, and then there's a lot, you know, 150,000 worth of clinical users using our solutions as well. So there's a lot. There's a heck of a lot of data, and there you go. That's our sort of, you know, the sort of data that's flowing into the platform from a population health perspective. And I won't touch on that for ages, bar to say that, you know, from a population health perspective, the general practice record is really, really quite key. It's about 80% of anybody's average health record is stored in there. But our whole point here in population health is about, I suppose, democratizing the use of that data. So traditionally, this large data is in the hands of analysts, but really we've got to find like really effective ways of getting it into the hands of clinicians, because that's where the difference can be made. So from our perspective, we've got different data stores as well to make sure that we satisfy like the information governance and clinical safety side of things. So anonymized and pseudonymized data for secondary uses, and then identifiable data sets, which mean that a clinician could access something like a Power BI dashboard, click on a record and click on a particular metric and get into a patient record straight away, which they can then use to make an action from. And we also link in a whole load of external data sets as well. And I've mentioned the ACG system, but also, you know, reference data being really key, or, you know, national data sets, SUS data too, so we can have a really holistic view of our population and in acute care too. So that's what we do. Lots of different use cases. Thought this might be interesting for you to see. Not traditional. I'm going to say traditional. I don't think there's a such thing anymore in the NHS as traditional analysts, but I'm thinking back to my days of when I worked in acute hospitals, and I'd do waiting lists and I'd do lengths of stays on particular wards and things like that. It's getting quite innovative, because we're looking at it from every angle now. There's a great webinar that's also coming up, I think in July, around fire safety checks. Just to call this one out, this is about using population health data to inform where you target your fire safety checks from the fire service. I mean, who'd have thought that we could get something like that going? But that is a use of population health data and linked data for a really good purpose, that is about a public health issue, you know, of safety in homes. You know, optimizing waiting lists, can we find our patients who are the most complex? They've got the most complex lives because they might need different types of care. So there's loads and loads of different types of use cases. And essentially, these types of use cases, the majority of them are Power BI dashboards, which are deployed out at an ICB level, and they're available to many different types of users. And some of these are secondary uses type analytical use cases as well. So lots of different stuff that we do. And I always touch on this, but just because the work that I'm really, really proud of in the past, it probably seems like ages ago now, but all the COVID work we did a heck of a lot within Graphnet. And, one of the most strangest things I've ever been involved in is analysing the data of people who've been to club nights in the middle of COVID to see about their transmission of COVID. Just really, really working with events organisers, NHS, data, public health. It's a really interesting mix. Something I don't think I'll ever come across again, hopefully. But optimization, so seeing the effects of how sharing data with anaesthetists and perioperative teams in acute hospitals can make a massive difference to how they process patients through for waiting for surgery, how they keep them well. So the ability to open doors to clinical teams is amazing with population health data, and the ability as well to look at the more holistic side of health, fuel poverty in Cheshire and Merseyside, for example. I mean, it's happening in lots of different places, these sorts of use cases, but health equity is a real issue. And, if you can only optimize someone's health so much, but when poverty comes into play, it's a different matter. And bringing that sort of space together to transform the way that people work as well has been fantastic and fascinating. So they're just some of my favourites as well. So I'm going to start off with just that, these sort of reflections as well. So Henry Ford makes cars, well, did make cars, he's dead now, he's very old, but everyone knows about Ford cars. But the essential thing about like Henry Ford was that they learned about everything that they did, and they made their process so that they could get those cars off those production lines as quickly as possible. And I always say it to my team as well. So everybody does make mistakes, we learn from them. It's how we make things better and we improve. So we've always got to be on that path of self-improvement. So if something knocks you down, just learn from it and get up again. And that's like that's the approach we try to take. And I suppose the one thing as well is, as an analyst team, we if we do make mistakes, we solve those problems together, but we also achieve together at the end of it. So everything always improves. So I think it's just a really important lesson that we've always got to get, that nothing is ever perfect, right? Now, when we're starting with, I'm going to jump right into use cases and where we start with getting going with these, because actually, if you're going to be, what you've got to always think of, I suppose, is that when you're implementing an analytical use case, so whatever that might be, could it be trying to find frail patients, because we know that the ones who are most frail keep ended up in hospital, or they keep having to get they're always waiting in ambulances to go in. So how do we try to prevent that from happening? If you don't know the reason why that keeps occurring, how can you solve it, right? So there's something here. I know it's really, really simple, this, but it is about understanding the problem before you start, because actually the thank you no, but no is something that I've come across as an analyst many times in my career. So we've worked really, really hard because somebody said, we need a dashboard. Has anyone said that? We need a dashboard. Let's create a dashboard that's about, let's think, COPD. So somebody from, an analyst goes away, creates everything about COPD, but will it actually solve a problem? And I've certainly been in, a scenario over the years where, well, no, there's one particular scenario where we didn't really understand the problem when we started to build what we were building, but we were told to build something. We scraped together a little bit about what we knew, but we were never able to talk to the end clinical users or the subject matter experts about what it was that the actual problem was. So we had no ability to scope it properly. Now, what that meant was that it took us longer to do, because there's too many misunderstandings in what we were scoping and what we thought we had to do. But also because we could never speak to the people who were going to be getting this piece of analytics at the end, that when it was presented to them, they said, well, thanks for this, it's really good, but actually we don't think this intervention actually works anyway. So we probably won't do it. Now, actually, that was what that meant for us was that it was a massive, massive waste of time because there was probably about 40 hours that was spent on creating what we thought was this great piece of analysis, quality assuring it, preparing documentation, lots of different types of things, getting ready, taking away someone's clinical time as well, because no one really understood what they were trying to do at the start. So the main thing is now this, I know everyone knows how to understand a problem, but there's a framework in which you can work in, and you have to do this before you start anything, because if you don't know what you're doing, you just can't get to the end of it. So, what is going wrong? So for those patients who, we've got these pressures with these frail patients, what is it they're going wrong? When are they getting admitted? Is it always at night? Is it the patients who've just been come out of hospital before and they keep ending up back in? Is it because they don't have, what is the solution and is it causing, an A&E admission, or is it causing a patient to stay in a bed for like 10 days? What's happening? Who's affected? So what type of patients is it? Is it those frail elderly? Or actually, is it our patients who have been taking particular types of medications that are making them fall over and end up in hospital? And what's the effect? What's the clinical pathway or setting? So, we could create a load of analytics that were targeting at GPs, but what if the team is going to deliver the care is actually a community team, and they're the ones who are going to do it? How do we make sure that they can get access to that right type of information, and what is it that they're struggling with? So if you took an example of pure poverty, those clinical teams who are working with these communities that have got lots of respiratory disease, they can optimize medically as much as possible. But unless they are armed with the information about how they can solve, a patient's problems more holistically, economically, possibly not, but maybe they can improve their house to make it warmer or something like that, they're never going to solve the problem. So how can we give them the ability to talk about things in a different way with their patients, and what sort of insight can be actionable as well? So at the end of it, does a clinician have enough information to be able to take action? So this is just, little steps to think about how you understand the problem. Now, what what I always say as well is that when you've understood the problem, the first question that you need to actually ask here, I've put it in the relation to a dashboard here, but because dashboards are like literally everywhere, I mean, Buzz Lightyear saying it here today, but there's so many dashboards within the NHS, there's so many sources of information. The first thing that you need to really do is stop and say, like, do I actually need something else? Or can we iterate something that works well, that what we've already got, or could we make some sort of changes? It's the question that you've got to stop and ask yourself straight away, because it might not be that you need to do something completely new. And there you go. One of the lessons from success is that iterate what you've got works really well. So I keep mentioning Pure Poverty, but I think we're on our 8th version, just about to present a new version of that this afternoon to a clinical network. So, there's and all we're doing on that is tweaking things and changing it, because as things in the NHS change, patients change, new medications come out, reorganisation. So we've got to work in that different way, but always stop yourself and say, do I need anything new? So the next bit really is I just want to talk you through our structured scoping, really, and this is a document that I can share with you afterwards, and I'm giving you one here that is populated so you can see. It's not populated completely full, but it's got quite a lot in there, but it's just a structure for how you can gather information. So we've got a phase development approach that we walk through, and very briefly, we'll get a request. We need to check it. Is it strategically aligned with priorities? And that would be your own priorities of what you need to do within your organisation. Is it feasible? I mean, that's your stop. Do we need something new? But is there something that's going to take 6 months to build, and that's really costly? Or could you do something else? And can you actually do it, because does the data exist to do what you need to do to solve that problem? You need to align it and look at how you prioritize the work, undertake some solution design and scoping. So that is going to be your collaboration. I'll talk about clinical engagement a little bit later on, but that is about that sort of collaboration, because this solution design and scoping is the very first part of when you're talking about transformation as well, because that's what population health analytics are a tool for. So that it's really important to get this scoping and design right. Governance, so information governance and clinical safety, like really important. Clinical safety and information governance, if you know, you can't, unless you're satisfying the requirements for that. So you've got the correct legal basis for what you're doing, and also, is it safe to do it? You can't really continue, and that's something that's always in the back of my mind about any direct care use case. The clinical safety element of it's really important, and we've got a structured way of checking that. Solution development as well, go in, check that, do your quality assurance, and always pick a pilot, and that's where again your clinical engagement comes in, with getting that proper checking done, ensuring that it's fit for purpose, and then solving any issues, and this is where the iteration as well comes in. And then I've just put down there sort of benefits, evaluation as well, and actually I'll come to this a little bit later, but evaluation is something that has to be tied in right at the start of when you're looking at what you're doing, because that is one of your best chances of success as well. So I'm just going to step through this, and this is you know, this is some work that actually we're working on at the moment, and it's a piece of work around medicines management and how can we try and reduce the I suppose improve safety for patients around polypharmacy, but also reduce the amount of polypharmac patients within an integrated care board, like in that population. So the first things that we're doing here, so this is about understanding the problem. This bit here, if you can't get who these customer owners are, well, you should probably stop there, because you don't have any clinical buy-in to be able to do it if you're not working with some clinical leads. They could be service leads as well. So ideally what you want is you want the team that's responsible for the transformation, and you also want those clinical leads who are your owners. And then you want those key sort of benefits summary. And this could be like the logic model that might relate to an intervention that you're going to get and pick up. But it's going to give you the sort of information, but also like the user benefits of what gives you the benefit of being able to use some analytics as well compared to what you've got at the moment, right? So there's some scoping there. Some key deliveries that we want to do, and here we've just outlined we want a direct care one, its secondary uses, and then also the mechanism to export. And then user stories. So I've only got a couple of them in here at the moment, but user stories are really important, and that's about describing the way that somebody wants to use a dashboard. Now, this might seem like a lot of information, a piece of analysis, but if you think that you're trying to get a piece of analysis to be used by clinical teams, it's worth putting in the hard yards to just get it all scoped out right, so you understand it completely. And it's just going to give you a structured way of doing that. There's some mocking up here, and you can see it. This is a real mix between randomness on Excel, and actually it doesn't matter what the numbers say on here, but there's a bit of a mix here between Power BI and also some mock-ups of some little charts. But it's about explaining exactly how something needs to look in the design, but doing it formally. With the conditions. So we always have I've not included them on this view here, but in the notes section we have all the metrics, and we collect them in an Excel spreadsheet as well. And then there's a second page of it to just say how it looks, and then right through to a patient details page, and then information about all the filters that you might need and how to use, that's usability of the dashboard, denominator population as well. And then these are bits in here. So I've included actually the instructions that we give to Graphnet analysts in here for you as well. But we have a load of different questions that we ask that are designed to draw out the things that we need to think about. So it's like coding definitions, the time periods, any specific calculations. We attach spreadsheets in here. In the access and security, who's going to access it? How does it need to be secured to satisfy like information governance? Is it going to be used by GPs? Is it going to be used? I mean, this is all a little bit more technical, but it's about gathering that information at the start, because when you're building, your queries or your data models, like a semantic model in Power BI, you need to know this sort of information at the start. So you're kind of building up the information you need as you're going. And then just these 2 pages here, which relate to clinical safety and information governance. And you might want to think about an approach for this as well if you work with like a third party like Graphnet. So, if you work with another company who does to use page as well, which clinicians can use at the very beginning. And then on one of our main tools as well, which is called the enhanced case spanning tool, we put it right at the top. So the first thing that the user goes into is how to use it. And also, you know, the about page here has a load of different definitions. So if somebody is looking at a particular data item, they can go straight to the data definitions. They can get, you know, and this is a long list of data definitions. But that's really, really important, and it's about understanding things. So if you look at a dashboard and you say, oh, hang on, that's not a value that I recognise, make sure that you explain that at the start. Make sure that you explain your denominator population as well. And I think just on my current slide, I'll just pop to the next screen. So one of the key things as well, this is some text actually from up in Cheshire and Merseyside, where we have some analytics in a dashboard as well, which looks at using the live population health data to recreate national metrics. Now that has challenges in it because when you're comparing it to national metrics, it will be really different, because national metrics, such as things like fingertips and that sort of style of data, it's often latent. It could be a year old. And in population health data, it's ever moving. It's a moving sort of situation. So being able to explain really, really clearly limitations in using data, but also differences between local and national metrics is also really important as well. So and things like opt-outs, why is the difference? So, you know, you can get the comparison of, we've just gone and run a big search on our EMIS Enterprise solution and it says 500. Why does yours only say 450? And your answer is probably something like opt-outs, but you've got to be able to make sure that a user knows that at the start. And that is a cultural thing. It's about understanding that population health data is different in terms of like published commissioning data sets or national data. So there's changes there that you need to be aware of. And just to touch on that, I don't think I had anything else on there that I needed to really talk about. Yeah, just at the end there, really, just engaging with those clinical champions, digital leader and working groups. That's the way that this works best, because, you know, I think if you can get that clinical leadership and that ownership, analytics will fly, because they will get used, because clinicians work in their networks, they talk, they share, and they will share their advice on how they implement. They will share the highs and the lows, and it's about being able to harness that. So I think it's about not walking away once you've implemented something. It's always having in mind that you've got to check out what you're doing, evaluating, iterating it, and plan that in, because something is never complete from the first time that it's done. Now, the last thing on here is really about embedding the need to evaluate from the start, because improvement is likely to be much more sustainable if you get yourself an appropriate framework for evaluation right from the very beginning. We've got to prove that everything we're doing intervention wise, because everything costs something, we're not able to save money in the NHS, so we've got to try and avoid cost, more so, you know, cost avoidance rather than cash saving, I suppose, at the moment. So one of the key things that we work with the clinical teams as well is about being able to prove those changes, even if they're efficiency savings. So right at the beginning, and it's something I can share afterwards, actually, I haven't got it in my deck today, but a framework for how you would gather the metrics together, for how you would look or decide and talk about the most appropriate methodology. So I'll just get to that now. So evaluation and iteration, and these are my last slides. So I guess I'm just going to talk very briefly about some evaluation methodology, because perhaps that's you know, if anyone's interested in evaluation methodologies that we talk about here, maybe that's something for like another lunch and learn if you've not done that sort of thing before. But I think like failure in, you know, trying to implement your use cases comes from not thinking about evaluation at the start. And I know I've said that about 5 times now, but it's just really, really important. You know, I've worked on really valuable use cases where we know it's made a massive difference to the patients. It's made a big transformation, a positive transformation in the way that clinicians work. but because we never, the data was never collected at the start in the right way, haven't been able to prove it properly. And that feels like really criminal to be working that way, because we don't want to let down those clinical teams who are working so hard to change the way that they work and really like adopt, new ways of working. So that's one of the things we need to do, that because that's where your failure comes in here. And I've got stories I could tell about that, but if we can look at how we can, evaluate from the beginning, I've got a great example of some work that we've done on remote monitoring, where because we thought about the fact that we were going to do a proper solid, evaluation that was based upon using propensity score matching, matched cohorts where we could look at the comparison between patients who were, remotely monitored and those who weren't. We were able to do that statistical evaluation from the very start, which meant that we could have success in the use case as well. This is my last, I think this is nearly my last slide, but I had this at the beginning, this sort of virtuous circle where we've got the insights that leading to actions, feeding them back in with the outcome analytics as well to this health improvement program. But I suppose what I just wanted to touch on very briefly was that there's loads of different ways that you could evaluate, and these are just a couple of examples actually. So the one at the top is about a practice that used segmentation to inform the way in which they brought their most complex patients in for their annual reviews to make sure that they were reviewed before winter, and essentially to try and improve their QOF attainment as well. And I think what you can see here is that right at the bottom, that compared to the average, they did do better for their most complex patients than the average for the CCG. So for them, for that type of intervention, just looking at their attainment was like an appropriate methodology, because it proved what their logic model was trying to do at the start. Let's improve it. The one at the bottom here is just an example of some evaluation work that we've done. And I suppose what I'm going to say about this is a piece of analysis using propensity score matching, and what it's saying is that the significance level statistically was that A&E attendances, the reduction in them was significant, okay, statistically. But actually, the layperson looking at that chart might look at it and say, whoa, don't really understand what that means. So I suppose there's something here about being able to decode and say, well, actually the actual figure of A&E attendances that we avoided per patient was this many, or this many in this group of patients. So this is there's appropriate sort of evaluation models for lots of, for different, and it's about finding the right thing that's appropriate. And also for some methodologies, you have to wait a certain amount of time. You're going to have to build up your data, get like a sizable cohort. So it's about like being able to, I suppose, provide insight through regular monitoring that helps you learn and inform the health improvement program. It's about being able to find the most appropriate style of evaluation that proves what you've been doing, or if it doesn't, allows you to fail fast. But it's also about making it explainable as well, because not everybody understands the statistics that sit behind it. So it's about finding the right type of methodology. Right, and just a reminder here. So yeah, Winston Churchill. I'm not a massive saver of Winston Churchill quotes, but perfection is the enemy of progress. So I think my hope today for you is that I hope you enjoyed the session. But if you can take anything away from it, it is that it doesn't have to be perfect. It probably just has to be good enough to do what you need to do. Because if you try and make it perfect, which is an analyst trait, you might never get there. So it's always our best endeavours. And that's me. I'm done.
Awesome. Thank you for that, Sarah. Anybody have any questions? We have a bit of time left. There was one earlier on, Sarah, about someone was interested to know if you use Strata, formerly Shape, for your geospatial stuff.
So, for our geospatial stuff, we actually, yeah, I think we use, no, so for our geospatial type analysis, because we generally use Azure, so we use things like Azure Maps, or I'm trying to think, Darrell's on here as well. What's our other mapping tech that we use, if he's there?
I think, yeah, no, I think you're right. We use the ones that are built into Power BI, don't we?
Yeah.
Apart from that, we get a lot of data on UPRN and from Ordnance Survey as well. So we link everything down to an individual property. So that's where we can link in housing data and things like that.
Perfect. Thanks, Daryl. A couple of people asked to be able to see the document, which I think you said you were going to put.
Yeah, I'm
send
going
a
to send
copy out
that.
with the slides.
Yeah.
So perfect.
I was just saying, Ross, sorry, he was talking about shape maps, wasn't he? I've just read it. Yeah, shape maps we do use in our tools as well, actually. And we've just been through a very painful exercise to update every single shape map that we have relating to, the new IM&D, index of mass deprivation, multiple deprivation, I should say. So yeah, sorry, but yeah, I will provide a document so that you can have a copy of that. Just have a look there. Yeah, so the requirements document into a PowerPoint with DevOps or similar. So one source of the truth for requirements, effectively data